Good evening. Thank you for joining us. I'm here with Gideon Gill, who is the managing editor of STAT, and he oversees STAT's investigative journalism and special projects. He previously was at the Boston Globe, where he was the health and science editor for a decade, and had a hand in 3 Pulitzer Prizes. Gideon earned a biochemistry degree from Harvard College and a master's in journalism from Columbia University. He's also treasurer of the Association of Healthcare Journalists, which I've been a member of since the 1990s. And he also leads AHCJ's Boston chapter. And so for our listeners, tell us a little bit about STAT. What is STAT?
Sure. Well, first of all, thank you, David, for inviting me, and thanks everyone for joining. So STAT began almost 5 years ago, November of 2015. We were spun out of the Boston Globe, where we have common ownership, but we're set up as a separate subsidiary with an independent news team, independent financially as well. And we were set up to focus on coverage of health and medicine and the life sciences, and not just in Boston or New England like the Globe does, but to be focused on these stories nationally and even more broadly than that, because the life sciences is a global pursuit and a global business. And we focus on covering the science of medicine, as well as the business of medicine, and as well as policy. We have we're headquartered in Boston, but we have journalists in New York, in Washington, in San Francisco, LA, and Cleveland, and freelance writers in other places as well. So we're definitely covering these issues nationally, and we actually have a readership of probably about 20–25% of our readers are outside the United States. So we're, that's basically us in some thumbnail sketch.
Okay, so the way this works, I'm going to talk and ask a few questions. If you do have a question from the audience, please put it in the Q&A box. Don't put it in the chat box. That's just for me and Joe Bonner, who's my co-chair and who's directing this, and for Gideon. So please put it in the Q&A box, and we'll take questions. So I guess the first question I want to ask you is that you've been around 5 years, but now everyone's working remotely. So how is that affecting the way you, how is that different?
Sure. Well, as I mentioned, some of our staff's always been remote. So so it wasn't entirely new territory for us, but certainly it was very different to have most of the editors, for example, are in Boston. So in terms of figuring out, coordinating what are we going to cover, who's doing what, it first took a little bit of getting used to, but it turns out that inter-office messaging, like we use Slack, that works very well for coordinating. We have basically 2 Zoom meetings a day, one at 9:30 and one at 3, where the editors get together and talk about what's going on, and we found that that's all we need, and those tend to be very quick meetings, no more than 10 minutes. And then in between, it's just all on Slack or email, or we pick up the phone and talk to one another. And after a week or so, we kind of got the rhythm of it down.
So
I will say that it is starting. I am missing the social interaction with my colleagues. That's I didn't miss them at first, but don't tell them that.
We won't. Okay, unless they're listening in. So next I want to ask you, so around March 16th, New York City went into lockdown, and I'm sure you did around the same time. And your coverage has basically changed. I mean, you were covering a lot. I mean, the biggest story I remember you covering was the Biogen's Alzheimer's drug. and other things like that, and business models for hospitals and expansions and things like that. And now the main story is COVID-19.
Yeah.
And I imagine not every reporter on STAT was a infectious disease person. I mean, they're covering that. So what's the approach? Because you also do a lot of business stories. I mean, like I know Matthew Herbert is a friend of mine. He covers business, and you have traditional health reporters. So how is that working out?
Yeah, so we actually began covering this story New Year's Eve, so well before March 16th, when Helen Branswell, who's our very highly respected infectious disease reporter, tweeted she saw a report on a listserv, infectious disease listserv, about mysterious respiratory illness in China. And she, with foreboding, so her background is she had previously worked for the Canadian Press in Toronto, and was one of the lead reporters covering the SARS outbreak in 2002, 2003 in Toronto. And she tweeted out New Year's Eve that this was looked remarkably familiar to her, like SARS. And then we published our first story on the site just a couple of days later. And at first, it was just Helen reporting it, but within a few weeks, she was telling us, and it became clear that by third week, end of the third week of January, I believe, she wrote a story saying, public health people think this could become a pandemic. And even though the president may have not read that story. We quickly began assigning other reporters to it. And we have a fairly small staff. We have 16 reporters on our staff. And as you said, some of them are focused on covering science. Some are more business reporters writing about the business of pharma and biotech. We have 2 reporters in DC covering Congress and policy, the FDA. But it turned out that all of them were needed, because this is a story that's science. It's a story that's about the business of making drugs and vaccines. It's a story about regulation, the FDA, the CDC. And so eventually everybody got pulled into it. So there was a point where every single reporter on our staff was covering the coronavirus. In addition to, we brought in a whole bunch of freelancers to complement our coverage. And then we also very early on made all of our coverage of the free. So I didn't mention that we have a subscription model. We started off as a free site, and after a year, we launched a subscription product called Stat Plus, and that now generates the majority of our revenue. And so we had a challenge there, because we felt there was a big public health story, and we had an obligation to readers to make it free. But it did present a challenge to us, because how do we justify charging people? It's not inexpensive to subscribe to Stat. How do we justify to them paying when we're giving, when just about everything we were producing at one point was free?
So what story are you really proud of that's been done in Stat that we wouldn't read anywhere else?
So our approach, because we obviously, we don't have the size staff like the New York Times does or the Washington Post to devote to this story. So I think what we did is, first, we were very early on it. We had, I think, probably had more people reporting on the story early than anyone else did. And so we started off doing a lot of explanatory journalism, explaining what this thing was, what we could say about how is it spread? All the questions everybody knows. How is it spread? How is it? How do you treat it? What are the early symptoms? All that stuff was unknown at the beginning. So we were explaining what we knew, what we don't know, and we also very much tried to give people a sense of what to look for down the road. I think the stories. I think we've broken a fair share of stories. We wrote the first story about problems, for example, with the Abbott rapid test for COVID-19. We were very early reporting the problems with distribution of remdesivir after it was given an emergency use authorization. We were the first ones to report on the preliminary results of the remdesivir clinical trials. So those are some scoops. But also, there are other stories that I thought that I'm proud of. Helen wrote a story at one point about what we called in the headline, the magical thinking of a lot of public health experts, people who should have known better, who, despite signs that this was going to be much worse, to be very bad, were sort of in denial. And this were like people at the CDC, not just people at World Health Organization, CDC, other important public health figures. We wrote a story about that turned out to be, I think, prescient about how there were second thoughts about, even as there was all this in New York and elsewhere, there are all these concerns we're going to run out of ventilators. We wrote, I believe, the first story that pointed out that there was people who were wondering whether we needed to be putting as many people on ventilators as we were at that point. Early on, going to the ICU and people you look at the blood oxygen level and that dipped below 93 or 94, and they would put you on a ventilator. And they then began figuring out that oddly, people with COVID-19, they could be high, they could still be breathing well, even though their blood oxygen levels were falling to a point where you ordinarily would put somebody on a ventilator. So those are some of the stories. I guess the other one I would just mention is one we published recently, because in addition to sort of news and more explanatory pieces, we've also done a number of, I think, important narratives. So we have our Eric Budman is one of our reporters embedded in some of the hospitals in Boston, and was able and produced a number of really wonderful stories. Most recently was a story about a hospital food service worker at Brigham and Women's Hospital, who was a Haitian American woman. She was the first worker in the Brigham system to die. And he wrote a story about her, but it was really a story about, that really got at the why. So her death was part of a pattern that was unexpected, because you would have expected that in a hospital environment, the workers with direct contact with patients would be the ones that were more likely to get sick. And in fact, what they were finding is that the workers with very minimal patient contact were the ones getting sick. And so these were the kitchen workers, the environmental services workers who clean rooms. And as it turns out, the reason is, as we now know, is that the people who are mainly getting sick are the essential workers, the people who live in communities with dense housing, lower income, lower paid workers, Black people, Latinx people, and so her story, he managed to weave all of that together into this narrative, and it's on our homepage for folks who want to go look at it.
So, so any COVID story, anyone can see, correct?
Yes. So all of our, so we've written more than, last time I counted, it was over 700. We're probably up to 800 stories about COVID-19 at this point. And we have, if you go to our page, statnews.com, on the top, there's a click on coronavirus, and that will take you to a landing page with all of our coverage.
So this has been a pretty common theme when I do these interviews on COVID-19. And people say to me, well, the public experts, first told us to wear masks. They don't tell us to wear masks. Then the newspapers cover it. And then, then the hot new drug comes out, hydrochloroquine, and then now they say it's not so great. And then they say that we'll have a vaccine by October. Now we won't have a vaccine by October. So people say, I don't know what to believe. I don't trust anyone anymore. And which I'd say, well, first of all, science is something that evolves. And I would rather get sick now than rather than in March, because people know, don't put me on a ventilator if my, pulse is at 94. And they have experience. But do you think it's, also, the governors, president, they attack the media. Do you think all of this has hurt the shaking up people and not knowing what to believe and what to do? What do you do to address that?
I think there's enormous interest in this story. Our readership has grown more than tenfold since the start of the pandemic, and I think people are coming to us because they think we're a source of credible information. Some of them are coming to us to judging from the comments they leave, because they're unhappy with, sometimes with stories that are say critical of the administration. But by and large, I think people are coming because they really are hungering for accurate, thoughtful information about the pandemic. I definitely agree that the attacks on the news media have undermined us in the views of many people. I think all we can do is be very transparent with our readers, which is why we try, when we write stories, to say, here's what we know and here's what we don't know. We were writing from the start that hydroxychloroquine, that the early studies were not at all persuasive, and you had to wait for randomized trials, which then showed that it didn't work for hospitalized patients. So I think we've tried to be very careful and science-based. It's basically been the guiding principle behind everything we do since we launched.
So do you find that you have to explain things to people, since there is, so many new people reading, like what is a phase 1 trial, what's a phase 2 trial, what's a phase 3, and kind of manage expectations that way?
That's a really good question, because before now, the majority of our readership, I would say, were people that are, that are in the life sciences, that are professionals, that are doctors, scientists, executives at pharma or biotech companies, or people that are in that field. We have a somewhat broader readership than that, but a lot of them were that way. And I think when we decided we're going to open it up to a general audience, now we're on the Apple News app, for example, and so you can't get a more broad general audience than that. And so we have worked to be more, to not take things for granted, what people know. And one of the things we've done is done a lot of explainer videos that are sort of animations that try to bring topics like how does a vaccine work, something like that, down to a very simple level.
All right, so I'm going to start taking questions from people. And so please put your questions in the Q&A box. I have 3 questions in the Q&A box. I'd like a lot more. So this question was given me, with so much data coming out about COVID-19 all the time, how do you ensure that your stories add meaning and don't just skim the surface? And also, what is your take on reporting about preprint manuscripts? And you'll explain that.
Yes. Okay, so the first question is, we've taken the approach that we don't write about every study. There are way too many of them. And I think that there's a lot of very incremental studies, and you can't really give meaning to readers based on any single paper. I mean, there's occasionally been important papers, when there's the report on a clinical trial of remdesivir or yes, you're right about that. Even though, unfortunately, and this is related to the preprint. So let me tell you, is that a lot of this, the results, for example, of these trials is coming by press release, not by actual publications journals. So that leads then to what a preprint is. So preprints are scientific papers that have not been peer reviewed, and that researchers post on what are called preprint servers. And these began actually not in the life sciences, but in the physical sciences. And there were places where scientists would post papers to get comment from their colleagues. Hey, here's a draft. Basically, it was their first draft, and they were sharing with, and it was a way to share it easily with a large number of colleagues who could kind of get, poke holes in it. And so it was sort of a pre-peer review process. Those preprint servers, however, are open to the public. And so we've been looking at those they really started coming into vogue in biology and in medicine maybe 2 or 3 years ago. And now with COVID-19, virtually everything is being published there first. And on one hand, that's really good, because it's a way to, in a situation like a pandemic, you need to communicate and share knowledge really fast. On the other hand, how do you tell the junk from what's real? And so we will not write about a preprint without going to other scientists and saying, tell us what you think of this. Like we're not smart enough, or even though we have very experienced science writers, we're going to go to the experts and get their interpretation of it before we decide that this is something we want to write about. Did I answer the question?
You did. Very good. Thank you. So do you think journalism could have done more or could do more to have greater impact on policy or public sentiment and better prevent COVID transmission?
Journalism. I mean, I think it's hard to, journalism isn't one thing. So there are many different organizations, and they cover the story in different ways. I think that, I actually think that publications that I go to, like our site, the Times, the Post, NPR, Kaiser Health News, the Wall Street Journal are doing a very good job. And we're and it's a good job in terms of writing stories. I think the graphics that you see news organizations producing, as well as organizations like Johns Hopkins and other modeling groups are really phenomenal. Anybody can go on and look at and track what's going on in real time virtually. So I think there's a lot of information out there, and there's also a lot of good analysis and interpretation of that information. And if politicians and policymakers aren't following it, I don't think it's because of a lack of I don't think it's because journalists aren't doing their jobs. I mean, I think it's because I think, public health agencies have had their hands tied in many places.
Okay. Here's a question. What do you think about the current state of testing for coronavirus and antibodies against the virus? To what degree are they accurate? How much can we trust them? How can persons know whether the results are trustworthy? So I had a test. I was sick December 31st because I read her tweet. I was very sick December 31st, first 2 weeks in January. And I swore that I had the coronavirus, got an antibody test, and it was negative. So doesn't mean it's right, but I mean, that is a question people have. I know that the test for the coronavirus itself is pretty accurate.
Well, no, I wouldn't say that. So first of all, there are over 100 tests that have been received emergency authorization. So let me talk about. So they're different tests. So there's the diagnostic test for the coronavirus, for the COVID-19 virus, and there. As I said, there have been 100 or more tests that have been approved, authorized under emergency use authorization. So the standard for approving a test to get emergency use authorization is very low, much lower than if you have to go through a normal FDA process to get approval to market a test. And that's because we were first of all, as everyone knows, we were weeks behind because of the screw ups at the CDC, and then we started rushing lab developed tests onto the market, and there are so there are numerous tests. There are a few main ones, and they are there are a lot of issues with them. So first of all, the biggest problem with these tests is how the swabbing is done. So, you had an antibody test. So if you've had a test to diagnose whether you have the virus,
No, I haven't had
the virus, you get a nasopharyngeal swab, and that gets put up all the way to the back of your nose, all the way as far as you can go in your nose. It's actually into the back of your throat because your nose joins up with the back of your throat.
It's not pleasant.
No, it's not. And so if it's done right, and you're infected, you'll get the virus there. But it's very hard to do because patients don't like it. So one issue is that the swabbing isn't always done right. Another issue is that if you test people too early, like early in the course, like you could be in day 2 of having been infected, and you go get tested, you may not show up as positive on a test because the level of the virus in your nasal passages is not going to be very high, and so that's another reason that these tests, and as we know, you can be infected even without having symptoms, and so and so the studies have been done have said roughly that as much as a third of these tests, of negative tests, can be false negatives. And actually, if you read the authorization letters that the FDA sends to the testing companies, they say that a negative test is not proof that you are not infected. So it has to be taken into, you have to look at the whole patient and whether they have symptoms. And so you shouldn't rule out infection based on a negative test by itself. The other, yeah. So
here's a question. Considering the speed with which vaccines are being developed, what is your take on the safety of potentially upcoming vaccines? If a vaccine were available within 2 months, would you take it? You, and or not me, and or recommend that your family take it? I would not take a vaccine within 2 months.
No, I would not, because it's going to take longer than that to run studies that pick up the most common safety issues. And even then, the most rarer safety issues may not come up until these things start being used, actually get an emergency use authorization to start being used. So one of the concerns is that vaccines can cause, in certain circumstances, can cause a kind of an immune overreaction. And that's been seen with vaccines. So that's a concern. And the other thing is that some of these technologies, so Moderna, which makes what's called an RNAi vaccine, has never had any product approved. And so there's no RNAi-based products, vaccines or drugs or anything that are on the market. And so we don't know, there's no experience with some of these things. So I think we have to be cautious about safety. We also have to be realistic about how effective they're going to be. The first round of vaccines, and Helen has written a number of really excellent pieces that explain this better than I will. The first vaccines, may not be all that effective. And in fact, most people think so the very best vaccines prevent you from being infected in the first place. And the reason that that's good is because A, you don't get sick, and B, you then can't spread, you're not going to spread the infection. So the thinking is that, and this has been seen with other coronavirus attempts to make other coronavirus vaccines, is that the very best we can hope for is a vaccine that will make serious COVID-19 less serious. So patients, it'll prevent pneumonia. Patients won't have to go on ventilators. That's a really good thing, but it may not prevent people from being infected such that they can spread the virus to other people.
So I'm going to combine these two questions. Are there any kinds of COVID-19 stories that you'd like to cover more and would like to see more pitches on? And the second question is, are you making freelance pitches for COVID and or non-COVID stories?
What was the second one? Do we take freelance pitches?
Are you currently taking freelance pitches for COVID and or non-COVID stories? And that came from an anonymous attendee.
Okay. We do take freelance pitches.
You can assign, if you want.
Yeah. We do take freelance pitches, and for both COVID stories and other kinds of stories. I will say that, there's a lot, as everyone knows, there's been a lot written about COVID-19. So in terms of freelance pitches, we're really looking for stories that are, that will provide an unusual angle or something that's fresh, some new aspect of the pandemic, a story. We're looking for, compelling stories. We look for geographic reach. One of the biggest challenge to covering this pandemic has been that we can't travel. You can't, as a journalist, you want to go and and be where you're, go to report on the ground. And that's been enormously challenging. One, because you can't even, it took a lot of negotiation to get into the Boston hospitals where we reported. But, our staff is in, as I said, we're in Boston. We have a few people in New York. We have some in Washington. We have a couple in San Francisco. We don't have anyone in Texas. We don't have anyone in Arizona. We don't have anyone in Florida where this, where it's happening, where the hotspots are now. We didn't have anyone like in Detroit, which had a very bad outbreak. And so, so I'm eager for, for people that are in those places that I think you have a better shot at getting us interested. I mean, there's a lot of reporting can be done by phone, but it really does help to be on the ground. And I hope in the coming months we can begin to do more of that.
I was speaking to Don McNeil of the New York Times, and he said the biggest difference between covering this epidemic and others is that he was in Africa for Ebola. He was in, China for SARS or other places like that. And he's now reporting from his basement. Yeah. So big difference. And he feels that he's not bringing the same thing to it, which I do understand.
Yeah, so, no, you can't. I mean, if we'd been able to be in China, I think, we were basically, blind to what, we had to take, everybody had to take the word of the Chinese government. I mean, there were some journalists that were in China who've done really good work, but it's been very challenging because you can't go to places and talk to people on the ground. What's going on?
Okay, so here's a question. We know social media can be prickly, but how has it been helpful to your coverage, either in communicating or explaining findings in reporting? Or has it been the opposite?
No, I think, social media has been extraordinarily helpful. I mean, yes, it has its, nobody likes the trolls, but I think it's wonderful because you see, you see all sorts of things. Like you can see people post. Yesterday, I read a post from a doctor talking about, his wife had gone in to get tested, and 2 weeks have passed. They still haven't gotten the results. So stuff like that. It's like, oh, why are the results? This was in state in the South, and you're like, well, why is, we should go look. Why are the tests so slow in that state? You see, it's a way to get tips, you can pick up on you pick up on news. It's a wonderful tip service. Twitter, social media is also, it's how we reach an enormous part of our audience through social media. A big chunk of our audience comes to us through Twitter and, can I say Facebook, without getting trashed.
Yeah. So this is good. So one of the first interviews I did was with Carl Zimmer, and as you know, we get on this, so make sure we can see each other and all this kind of stuff. And Carl just said, "I'm really down." It's like it just got me on a bad day. So here's a question from where you sit, and you're in Boston. How optimistic or pessimistic are you about where we are headed?
I mean, so let me answer it this way. We did a story, I don't know, maybe 2 months ago where Sharon Begley, one of our really wonderful science writers, wrote a piece that looked at 3 scenarios for how the pandemic could play out. This was primarily in the United States. And one scenario was that we'd have after the original wave, that we'd have a lot of smaller ripples, and that it would start coming back, and we would have by then have, testing down. We'd be doing enough testing. We'd have contact tracing down. And so as soon as it came back, we'd catch it. And so you'd have these series of ripples until a vaccine arrived. Another scenario was that the initial wave would be followed in the fall by a massive tidal wave. And the final one was that we would just have a almost continuous high level of coronavirus, that you'd have maybe not a tidal wave, but high level. And unfortunately, I think we're headed for the third. I think that's the one we're headed for. When you look at what's going on, I just think that there's no coordination to anything that's being done. And, I was just talking to my wife earlier about, Disney World is opening this weekend. And I can't think of a worse.
Cases went up there 130% in the last 2 weeks.
Yeah, I can't think of a worse thing. At the same time that President Trump is talking about having to reopen school, that we need to reopen schools, we're going to have families with their kids coming from all over the U.S. to Florida, which, as you say, is in the middle of a huge surge in cases, get infected, come home, bring it back just in time for the start of classes. So I am pessimistic.
Fantasyland, Tomorrowland. Yeah, I've been to Disney World. I think it's unbelievable.
The other thing I want to just, you haven't asked me about this, but the other thing that of course, that's come in the middle of this is the whole Black Lives Matter movement, and I think for us, we see that as an important, it's of course an important story at all levels, but it's an important story for in medicine and healthcare and science. And as the pandemic has shown, there's the racial, the structural racism has made this very much a disease of that is striking Black people and Latinx people, and it's and so when we talk about it coming back, this is really bad news for those communities, and I think that's another reason I'm very worried about it.
I was shocked to see that PPE equipment is running out in Florida and Texas.
Yeah.
People are waiting in line 9 hours to get a test in their cars. And I had friends in Texas bragging to me a month ago how, our hospitals don't have cases, it's very low here. And I said, well, that can change, and it did. I'm sorry it did. So Gideon.
Yeah, I just had another data point that makes me pessimistic. Is yesterday I went out to a local school where and there were all these playground, like a soccer field and football fields and stuff, a local high school, and there were all these kids playing soccer, practicing football, not wearing masks. Dozens and dozens of kids all packed together. And so I just, human behavior is making me pessimistic.
Okay. So, apropos, why do so many people refuse to wear masks or not believe the science? I mean,
well, young people, I think it's just the usual sense of invincibility of 17 and 18-year-olds. I don't think it's got anything to do with believing or not believing in science. There is, there's such a, we've seen this, I think it's been very evident with the whole anti-vax movement, and that there's this distrust of science and of elites. And this is, the president picked up on this in his 2016 campaign. He appealed to that, and it's part of why he got elected. I think we've gotten into and part of this, maybe this is, I don't know, I've had arguments with friends about this, to the extent to which social media has contributed to this, which is the sense that people now rely on their social circles for information and knowledge, and they value their friends as sources of information more than they do scientists. And I think there was always that tendency, but I do think that social media has amplified that. And I mean, we could go on for hours talking about this topic, but that's my sort of initial.
So last year I was in Lindau at Germany, Nobel Laureates Week, and one scientist said about the mistrust, said, well, there are people who are against vaccines, but they want their cars built by engineers. They don't want them built by anybody. They want their airplanes inspected. They want to make sure that drugs are safe to take. So it can be selective. Okay, so here's a question. As the various efforts to develop a vaccine proceed, do you have a plan for distinguishing between test results that provoke false hopes and those results that represent true breakthroughs? So I guess the question is, your vaccine reporting, how are you gonna know?
Yeah, I think
tough question. Okay.
Yeah, no, so it's very challenging because as I mentioned earlier, a lot of the data has been coming out with just dribs and drabs. So we've been getting press releases from companies on, Moderna put out a press release about their vaccines phase 1 results. We still haven't seen a paper published. The NIH is actually running that trial, and they haven't published the paper. And as we know, there's been back and forth and disagreements between Moderna and the NIH. And so this is a real challenge because, we and everybody else wrote about that press release. I think the responsible thing to do is to write about that, but very clearly, as we did, say, this is incomplete. There are a lot of holes in this data, and we really have to withhold judgment until we see a published peer-reviewed paper. Yeah.
So here's
it's a real challenge. It's a very good question. Real challenge.
Here's a question for you. When this is all over, do you think all your new readers will stick with STAT, and what will you do to keep them?
Great question. No, I don't think we're going to keep all of them. I think a lot of people come in episodically. They get drawn by a particular story they see on social media. I do think our regular readership will have grown. What we're doing, we're doing a number of things. As I mentioned at the beginning, we've made all of our public health coverage about coronavirus free. And so we had this challenge. What do we do for our subscribers? How do we keep them? And so one thing we've started doing is, we last year started about a year ago, we started running events because our business model is that we have some advertising, we sell subscriptions, which is, as I said, the main source of revenue at this point. And we started doing events. And the events, we had a big event planned in May in San Francisco about health tech. And we have another event that we were planning in November, a big, what we call the Stat Summit. It was going to be our second one. That was going to be here in Boston. So we've switched both of those to virtual events. So the health tech event will be now in September, and we're keeping the summit in November. But on top of that, we are doing weekly events for our subscribers. And these are talks where we'll have usually one of our reporters will moderate a panel, either a one-on-one interview or have several panelists. And we talk about, some will be related to the coronavirus, but others are about other, unrelated topics. And so we've been doing these once a week, is basically to say we're doing this for our subscribers. So it's part of our effort to retain subscribers. We say to people, we hope that when people come to our site and they read our coverage, that they look around and they'll think, oh, this is a credible place. I can rely on what they're reporting. It's interesting, and I'm going to come back. So I think those are sort of two of the things. The other thing we do is we try to get people to sign up for our newsletters. So we have a suite of about 10 newsletters. And I hope all of you have signed up for them. We have can I give a pitch quickly? Morning Rounds, which goes out at 6 a.m. every morning, which is kind of an overview of the day's health news. We have a biotech specific newsletter that goes out also in the morning called The Readout. And then in the afternoon, we have Daily Recap, which kind of recaps everything we've published that day. And so those are ways that we hope to kind of hold on to people that come to our site by getting them to sign up for our newsletters.
So you're involved with the Association of Healthcare Journalists. When I first joined, there were only 90 members. There are a lot more now, a couple thousand, I'm sure.
We're about 1,400.
1,400, well, okay, close.
Yeah, more than 90.
More than 90. So they've been doing, I think Liz Seegert especially has been writing about things. And what's the role of a professional organization in educating the public?
Oh, well, so we see, AHCJ sees itself primarily as training journalists.
Right.
And for those of you, the journalists that are on this call, I hope some of you are members, and if not, I hope you will consider joining, because since the start of the pandemic, we've been publishing on the site lots of tip sheets and resources and pieces that highlight the work of other journalists. And we have a listserv where people can go and ask questions of their colleagues. There are regular webinars on topics related to the coronavirus. So it's really a great resource for journalists. And one of the things we've done is actually reached out. We've provided a special membership rate for journalists who aren't regular health reporters, but have been thrown into covering the coronavirus. So political reporters like in Washington who are asking the questions at the coronavirus task force meetings, they sure need to know something. So we're trying to get those people information about it. But secondarily, there are portions of the AAC website are free and open to the public, and we do push out content on social media, and there is some readership from the general public, but we are primarily focused on training journalists.
So this is my last question I'm going to ask, and then I'll let you go. So as you know, the last couple of years, a lot of healthcare journalism, they've been slashing budgets. At the LA Times, they didn't have a science editor anymore. The person I work for just said they're just going to do local LA stories on fitness and stuff. So do you think this pandemic is going to lead to a revival in writing about healthcare and science?
I hope so. I think that a lot of organizations have recognized the short-sightedness of that. I think, if the two of the biggest stories of our time, climate change and this pandemic, are integrally involved science. So how you can be a major news organization and not have a editor and a team of reporters focused on science, I don't know how it's mystifying to me. So I do feel that that newsrooms and top management at news organizations have gotten a wake-up call about this. So, yeah.
All right, so we do have a lot of journalists on the call, and since they wanted to know, how do they reach you? How do they pitch you?
Oh,
I can put your email on the web. Can I put your email on the?
yeah, my email is public, gideon.gill@statnews.com.
Okay.
And it's on the website. You can find me on the website, and happy to. It may take me. Don't fret if I don't get back to you like in 24 hours, because I get, as you can imagine, I get a lot of emails, but I will respond, and we're happy to entertain pitches.
Okay, so I'm David Levine. I'm co-chairman of Science Writers in New York with Gideon Gill, who's with STAT. I want to thank my co-chair, Joseph Bonner, who I can see, but no one else can, who's kind of directing this and doing the live feed on YouTube. And we're going to post this tomorrow on our website and also on our YouTube channel, so you can see it. And Gideon, I want to really, really thank you. I was hoping to see you in Austin at the meeting, but that didn't happen. So maybe next year.
Next year in Austin, I hope. Who knows? God.
Yeah.
But it's been a pleasure being here, and thanks everyone for tuning in.
Okay, thank you so much. I'm going to say good night to everyone, and everyone please stay safe.
Good night.